the following day, and 1 a.m. Tokyo. So jumping into today, our forum is a guided panel discussion with key opinion leaders from within our community. And it's something that personally is near and dear to my heart. A number of times I've gone to Johns Hopkins, having been invited to speak in grand rounds in their sleep medicine group. And I've made a point of scheduling time with some faculty at the Bloomberg School of Public Health. And even, you know, I've had some really nice meetings with their dean, and the issues that we're facing around myofunctional therapy have always been, for me, on the horizon, both on the horizon and upfront in my face as public health issues. For instance, we have a Perinatal Action Coalition, paclac.org. I got invited to speak at their annual meeting at the California Endowment. It's our largest foundation here in California. And I presented one of our colleagues' real works, something I've been involved with, we'll talk about today, the Testa di Linguina Frenulum Inspection Law. And this is a group that helps set policy nationally and internationally for lactation consulting, for perinatal application of policies and procedures for large hospital groups. And this was new information to them. So when I think about the public health implications, we organized a symposium at the Stanford Sleep Epidemiology Research Center with Maurice Ohayon and our institute, the Academy of Orofacial Myofunctional Therapy, 4 years ago. And we were talking about strategies for advancing myofunctional therapy, as well as prevalence questions. And the wrap up in the consensus, Dr. Ohayon, he looked at all of the panelists and all the extended community assembled, and he said, this is a public health scandal that we don't have guidance around frenulum inspection when we know the implications and the correlation to sleep apnea. So there are still people who consider themselves leading researchers out there fighting what they may consider a good fight and saying, we don't have to cut frenula, we can let it resolve itself. There are major national medical societies saying, putting this in actual writing, saying children can trip and fall at the age of 12 or 13, or they may even have a bicycle accident where it will tear and resolve itself, the ankyglossia. That is in a National Medical Society guidance statement, a National Medical Society, a Pediatric Medical Society. So the title here today, AAMS Forum, Public Health and Myofunctional Therapy. What is the cost of not treating someone who suffers from orofacial myofunctional disorders? Orofacial myofunctional disorders is a term that we helped come up with. It's made it into the medical literature. And what it stands for, it's an umbrella term of syndromes, phenotypes, and perhaps even disease states that are related to orofacial myofunctional disorders or orofacial myofunctional rest posture, chewing, breathing, swallowing. The stomatognathing system is a great term that's often used sometimes in China and in Germany and France. But we have a great lineup here. I just want to read through, Samantha, do you want to read through a couple of these questions here?
Yeah. So when we talk about myofunctional disorders and public health, we're really looking at, by the way, my name is Samantha Weaver. It's very nice to see you all here today. Mark is my husband. We're doing this together, and we are here broadcasting from our home in Los Angeles, and it's really wonderful to have everyone here today from wide and far. So we're looking at issues that are specifically around the prevalence of mouth breathing in the general population, and what are the strategies that we can implement or determine to examine myofunctional disorders as they are related to sleep disordered breathing. Traditional population surveys, and are these viable for OMD prevalence studies? And one thing is that technology that we had a forum about a couple days ago, how can this be enlisted to provide better patient data? We have several other questions about the costs and the treatment strategies, screening tools, and essentially what are the key research priorities that are bearing down on public health outcomes?
One of the key questions that I think bears exploration today, and we're hoping to get examined. We got an invitation to present late-breaking symposia for the World Congress on Public Health next month. So I'm on pins and needles hoping we'll hear some good news soon. But since we know that orofacial myofunctional disorders are multifactorial and we can connect the dots to major epidemics like obstructive sleep apnea that a billion or so people suffer from, and further downstream from this advanced disease state, or correlating are things like heart disease, diabetes, cancer, obesity, Alzheimer's, really the major killers in society. If we had a think tank that was comfortable with big data and they ran these kind of prevalence ideas, prevalence in the population of subsets of myofunctional disorders, I think we would really wake up the public health community. So I want to move forward with our panelists, and I want to thank everyone. Like I said, me personally, I dream of perhaps doing a MPH or a PhD in public health and coming up with some answers to these questions. But Roberta Martinelli, are you in? I know she was teaching a class. Maybe she hasn't come in. So I'll speak on behalf of Roberta. Roberta is a speech-language pathologist. Originally, she did advanced training, became a myofunctional therapist. And for about 10 years, I've been on a journey with her where we formed a public health committee in Brazil that was first funded by the Sociedade Brasileira de Fonologia, the Brazilian Speech-Language Pathology Society. And what we did was we took her PhD work on creating really the first medically validated frenulum inspection tool for infants and newborns. And we put muscle behind it. We hired a lobbyist. We hired a public relations firm that specialized in healthcare issues. And one of our team members, Roberta's mentor and a colleague of all of ours, Irene Marquezan, was elected again as president of the Brazilian Speech Society. So we had the good fortune of these resources. So in this journey, we managed to pass the first law in her hometown, a small city called Brotas, a city of about 20 or 30,000 in Sao Paulo state. She had a friend on the city council, I will, in full disclosure, say. We got a law requiring frenulum inspection at birth for newborns. So this is in addition to vision, hearing, blood. They have to have the bridle under the tongue inspected for restriction. And this was in September 2012. And this was such an exciting moment for me because the way we laid out this strategy, it was not just simply to make it easier for breastfeeding, latching, working on the trauma situation, but thinking from a public health perspective, how do we present a case where we can dream of preventing disease states, avoiding things which we've since gone on to show a correlation, like sleep apnea and tongue tie. We can avoid maxillary hypoplasia, perhaps, because if you have a low tongue rest posture, you're going to have a proclivity towards a high narrow palate. If you have a tongue tie, there's so many other comorbidities which could be related, which can be so easily avoided. So in this journey, our team collectively passed 18 laws in states and cities around Brazil, on the way to passing a federal law in 2014, became effective January 2015, requiring frenulum inspection at birth for all babies born in Brazil. And this is such an exciting development because it's about avoiding myofunctional disorders throughout the lifespan by doing intervention at birth. Low intervention, low cost, medically validated tools. And something I want to make sure is noted that we wanted to discuss today. The Brazilian Pediatric Medical Association made a very concerted attempt to repeal this law just last year. And the Ministry of Health and the state Senate and the House of Deputies in the federal government in Brasilia, this attempt at their lobbying firm, which I think, it's a pretty strong arm of medicine, pediatric medicine, this was defeated. It was absolutely shut down. There's too much data. It's overwhelming. The results are in. Frenulum inspection at birth is a public health milestone, an opportunity. And so I'd like to see if Eyal Botzer is here. I know he was driving and he was going to pull over. Eyal, are you there?
I can't pull over yet. Maybe within 5 minutes, I will let you know.
Within 5 minutes. Okay, so we'll circle back to Eyal.
Yeah.
And actually, this is maybe appropriate. Isabel Fiazot was introduced to me. She is vice chairman of a commission that just submitted its report to the Minister of Health on reimagining the first 1,000 days of life in France. She's a prolific author of, I think, more than 35 books. She's got a couple more in development, so at least 35 published. She's a tremendously passionate advocate for childhood issues. She's based in France, and I'm really excited to have her engaged. She's the winner of Rising Star Investigator Award for this Congress for great promise in medicine. Isabel Fiazot, welcome to this Public Health Forum today.
Yeah, thank you very much for having me, and I'm really glad to be here. And yes, you're right. Everything that you said is just very rich. It's evidence. We really need to do something for children from the very, very young age. We need to install a real prevention. It's so easy. The more I learn, and in all this Congress, I learned a lot. The more I learn, the more I know about what's happening in the mouth for the children, the more I realize how important it is to do frenulum inspection, but also how the jaw is positioned, and just have a little more attention to the baby just as he's born, his very, very young age. We can have a little attention, and we can help him. If we don't, then yes, we pay, but he pays. And the parents pay a lot, because it's not only money. It's so hard when you have a dysfunction, then your sleep is not good, then you can't breathe correctly, you don't eat correctly, and then the parents fight. Whoa, why don't you eat correctly? Why don't you concentrate more at school? And so on. So the parents just, they don't know how to deal with the problems the child has. Just a few days ago, I was in front of a small boy and his parents, and the parents were saying, well, can you help us? Because he has so many emotions. My son is hypersensitive. Has temper tantrums all the time. But I looked at him, and he had a so small jaw, and he has his teeth in everywhere. So I said, well, okay, it's not a psychological problem. It's a orthodontist you have to go and see. And this little boy was only 4 years old, but he could have went like this, and it would be harder and harder to do some things. The more I learn about myofunction, the more I see everywhere people with difficulty breathing, people with difficulty sleeping, people with so many difficulties that could have been treated before. So yes, I am with you, and I will fight for having a real prevention laws. We need laws to encadrer, to really be around the children and with the parents.
You know, I think it's so important to bring in the psychological aspect that you helped shed light on this. And we'll hear from someone later in the panel too, Karen Sproit from the National Institute of Health of France, INSERM, who has psychology training. So much of this is really overlooked. And I think collectively, we as a field need to look more at psychology, at psychological intervention and support. This is really a gap for us. And the impact on these children, I know one of our friends and colleagues, Dr. Stephen Sheldon, who edits the key textbook for pediatric principles and practices of sleep medicine, one of the co-authors of some chapters that will be speaking here later today. You mentioned orthodontic intervention. There's a new society that will be registered in Geneva next week, the International Pediatric Orthodontic Society, which will be the first international body to focus on this intervention at the earliest age possible, even if it's at birth. If we have a craniofacial morphology which is altered because a baby is born with a cleft palate, we think, okay, we need to do something. We need to close this. But if we have a baby that's born premature and they're intubated for 6 weeks or 6 months, we don't have policies and procedures and standards of care to address that. Are they going to be mouth breathing? Is their tongue posture going to be low? So I'm really excited about that. We'll explore that deeper in a forum on Tuesday on infant myofunctional therapy, but I think some of our panelists will touch on that today. But Isabel, it's a dream to have you engaged. I know it's a very serious and I think even sexy trend, if I can say that, in public health, to look at the first 1,000 days of life. There's a brilliant foundation based in Washington, D.C. that has expressed some interest in our work, first1000days.org. I encourage everyone to take a look at it and their work. And I really think that as a community, our institute certainly will be looking at this and has been developing curriculum around infant myofunctional therapy and intervention and frenulum inspection training, frenulum surgery training. We need standards of care. And which leads me, Ayal, have you pulled over yet?
Yeah, and I would add, can I add something?
Yeah.
Please.
Yes, I would say we really need to train psychologists because most psychologists are not aware that the position of the tongue, that the jaw can really make a difference. And that they don't really realize how much you need a body to handle your emotions, to cope with your emotions, to cope with life. You need a body in a good shape. You need sleep at night, a good sleep. So really, there is a huge impact of the myofunction or dysfunctions on emotions and on cognitive skills also. So really, psychologists should be trained. Now we are more and more in a society where the doctors, the medical staff have to come to psychology because there is always a psychological impact. It's always psychosomatic. And the psychologist should go more to the biology, go more to the medical people, because if we talk together, then we have the big picture, then we understand better. So we really have to stop working each one of us in a very small field and really see one boy, one girl. It's a whole thing. She has a body and she has a mind and her emotions. To deal with her emotions, it's not enough to just talk with her about her emotions. Yes, she needs to be able to handle them, to breathe correctly, to sleep correctly, and so on. So I wanted to add like this.
Yeah.
Thank you
This is
very
the
much.
training.
Thank you very much, Isabel. I hope we can see you when we have a body of knowledge meeting at Les Pensières in January in France. Anyway, Eyal Botzer, are you there? Have you managed to pull over?
I'm here.
Okay.
No, no chance I'll pull over because it's a traffic on the highway and I can't really pull over, but we drive so slowly so I can speak.
Okay,
So,
thank you. Tel Aviv traffic jam. Okay. Dr. Eyal
the eve of...
to introduce him, he's a dear friend and colleague, but he is involved with Sourasky Children's Hospital at Ichilov, the giant state-of-the-art medical complex, the University of Tel Aviv in Tel Aviv. And he's done, I think, more frenulum surgical revision procedures than anyone else in the world. I think well over 20,000. And he's a thought leader and passionate traveler. I think we've probably spoken together in at least a dozen countries. And Dr. Botzer, welcome to this public health forum. Thank you for your contribution.
Thank you. Thank you, Mark. Thank you, Samantha and Katrina. Thank you for inviting me. And all I have to say is to echo what's been said just now. The fact that it is kind of outrageous, the fact that we know the sequela of deterioration that may happen if we are not diagnosing in time the myofunctional dysfunction. And if we can get and trace it on day one, whether it's by the law of the tongue inspection or other team approach of body workers, myofunctional therapists and surgeons, to put the child right on track on the very first days of life and give them a better chance. And otherwise, all this sequela that was just described can be avoided. And we need also a very strong basis of research. And everything has to start from the beginning. And we are at the beginning now. So let's move forward and get those laws around the world and get this research moving.
Thank you, Eyal. Eyal received our Lifetime Achievement Award, our Florence Nightingale Award for Courage and Vision in the Advancement of Medicine at our gala this year. Moving on to our next panelist, Dr. Shannon Sullivan is a pediatric pulmonologist and sleep specialist. She's an amazing person. She's a recipient of our Rising Star Investigator Award for great promise in the advancement of medicine. She is a dynamo. Beyond having been a real anchor in the Stanford sleep team for many years and helping contribute and I think run for a while the Stanford Sleep Fellowship, she's shown up in leadership committees at the American Academy of Sleep Medicine, helped develop guidance and policy statements around driving and sleepiness. She has, with her passion to continue to drive research, she's shifting gears a little bit. I think she's starting a new post in pediatric medicine at Stanford while doing some work at the Stanford Sleep Epidemiology Research Center. And I think she's starting a master's degree in epidemiology at Oxford this fall in order to further her research chops. And we hope she'll be joining us in starting a PhD in neuroscience with some projects that we're excited to be working on with the French National Institute of Health all over the world. So thank you for your passion and work, Shannon, and your passion for helping children.
Thanks, Mark. I just had a couple of quick comments to add to this conversation. And first of all, thank you so much for inviting me. I think it's so great to have everybody here. We hear this term long haulers now a lot. And when I think about public health endeavors, you have to be in it for the long haul because it takes a lot, unlike clinic where you identify a problem, you apply your treatment, and then you measure and look for solutions. When you're talking about public health, you really are taking the long view when you step out of the clinic and want to address health and population. So thank you to everybody who's here and who's interested in this. So my first reflection is that, I think this area lends itself really well to traditional models of public health, and even the silos, so to speak, of public health, which are nutritional sciences, epidemiology, more recently informatics, and health policy. So when you think about this type of oral facial myofunctional disorders, you can understand how there are elements in all of those traditional silos that we can leverage to really be able to address these types of issues. And so thinking about sort of where to put our feet and where to land in terms of our efforts moving forward, I think it's useful. Because I'm interested in the epidemiology side of things, and actually my upcoming work at Oxford is going to be in medical statistics. So I'm really interested in sort of the details of planning research and how to further our knowledge base. I just have to put in another plug for really holding our own feet to the fire about case definitions, and understand so that we all, when we make all understand, we need to make sure that as we forward in the public health space, we're conveying consistent messages so that I can call up Isabel, and when I use certain terminology, she knows exactly what I'm talking about, and I can talk to a colleague I don't know, and they know as well. Let me know, is my internet connection a little bit stable?
Yeah, it went a little wobbly.
If that's better.
It went a little wobbly.
I had to move to a
So
weird
if you could
part of
just
my house because I'm
start
having-
back from your comment about case definitions and repeat that, I think it's really important.
Sure. Is this better with the video off?
Yes, yes.
Okay, great. I'm in an unusual area right now because I have work being done in my house. It was creating a lot of background noise. So my point there was that I think moving forward, being especially interested in being able to develop a language or a lexicon around what it is we're talking about, we need to be very clear with our case definitions, so that when we're talking to one another and when we're messaging outside of our own fields, that we're all talking about the same thing. And so is that a symptom-based definition? Is that something that relies on testing? Do we have validated tools that we can use in this space? Starting to really develop a language, I think, will be very important as we move into the public health space. And then I just wanted to put in a final plug. If you're interested, Samantha had asked a question about the prevalence of mouth breathing. And I wanted to point out that we have a little bit of data about this. It's a bit buried, I feel, in the sleep medicine literature, but the Avon longitudinal study is a great study to look at this. It was of over 12,000 children who were followed for almost 7 years at 6 months and then every year thereafter. And at 6 years old, 25%, and these are community dwelling children without any other diagnoses, 25% are habitual mouth breathers. And you can look at that development over time. And within that cohort, cluster analyses have been done that show that there's a late snorer mouth breather cluster that's kind of the sleeper cell, so to speak. They're asymptomatic at age 4 and they present with sleep disordered breathing symptoms. So you can know, there is already existing data to suggest what we need to do to be able to move health forward in populations, but we need to do much more. And I'm so glad to be part of this effort.
Thank you so much, Shannon, for your contribution.
And also it's so fascinating because when we look at lingual frenulum restriction in babies, one of the key markers is open mouth posture. And so if we can just get more people trained to look at these clinical signs of dysfunction early on, we're talking about parents primarily, and parents, teachers, educators, and again, the psychological ramification that Isabel is talking about, it really is going to go into how we train and educate the public. And that's part of our mission here, is to get more information from the experts out to you.
Well, I couldn't agree with that more. And I wanted to point out that in that particular longitudinal cohort study, really meaningful elements, including length of breastfeeding, changes in height and facial growth, in chin and nasal development, as well as a variety of behavioral and emotional outcomes were studied. And so some of this data is there, but a lot of this is about connecting the dots and then formulating the next best research question to go after to really help to further this story.
We love that study. Thank you for bringing it up. Give a shout out to Karen Bonnick and Ron Chervin, and you know, I mean, other points that we really look at. You know, the 10-point differential in IQ. There's also like a 60% correlation to a behavioral diagnosis, if I'm correct in citing the data. You know, I mean, huge, impactful quality of life throughout the lifespan outcomes related to this population. And you know, it's such a great set of data, and I can't wait to see more studies along those lines. And I'm excited to see if we can help catalyze some of that activity. So shifting gears a little bit, thank you so much, Shannon. Dr. Daniel Ng, who's staying up late tonight in Hong Kong. Daniel, are you there?
Can you hear me?
We met, yes, I can hear you. We met
Thanks.
at the World Sleep Congress. Christian Guimeno made a point of making sure we got together 7 years ago in Valencia, Spain. And we started, he made sure to sit me down and talk to me and give me a thorough grilling, which he continues to do to this day. But we started a public health dialogue exploring how to make Hong Kong a center for leadership in medicine, and how to bring myofunctional therapy to Asia. But thank you for your leadership. He's a recipient of our Lifetime Achievement Award and for the Advancement of Medicine, or Hippocrates Award, at our 3rd Congress in Rome, I think at a very young age. Also, if you ever have the chance of working with him in Hong Kong, he has some great dining club memberships in Hong Kong side. One, I love Shanghainese food, so he knows his way around. Thank you, Daniel, for being here today.
Thank you, Mark, for the invitation. It's nice to see you in good color, despite this month-long conference. It's the longest conference I've been in. Well, I think habitual snoring occurs in 10% of children. So it must be a public health issue, right? And so all the talk about the behavioral problems, neurocognitive problems are all result of sleep disorder breathing, okay? The question is, how can I move back in time for that kid with habitual snoring to change the trajectory so that they will not be habitually snoring, okay? So the problem is their pollution is getting worse, obesity is getting worse, and pollution make allergic disease more common. So you have this perfect storm: obesity, pollution, allergy. And all this, of course, makes the airway much more, the nasal passage, much more crowded, okay? And then tag on with that would be the tongue tie, which we talk about, you mentioned, and the preterm delivery. The pollution increased the preterm delivery, okay? So together, the baby would be born, would start mouth breathing very soon, okay? So there's very little we can do as pediatricians, okay? We give saline spray, and then we try to train them to breathe through the nose, but it's very difficult to do at the bedside, right, by pediatricians. So I think that the scenario right now is really calling for a not too expensive measure that could change the trajectory in the first few years of life. Okay, and I think orofacial myofunctional therapy has a potential to really change it in the first few months and first few years of life, so that the 4 years or the 3 years would not have sleep disorder breathing. So I think we have a big job to do to promote the recognition that mouth breathing is per se a pathology. And then we should train the clinicians, nurses to say the approach to mouth breathing. Of course, they'll identify the nasal blockage, they identify harsh palate, they identify the tongue tie, and then we empower the clinicians to recommend a management, which would be, of course, tongue tie release, will of course be muscle training, and that will, of course, where OMT would come in. Okay, but we need to have a collection of opinions to drive this forward. As you know, Mark, you've been in Asia for so long. Asians have much smaller jaw than Caucasian, so we are predisposed genetically. So it'd be important for us to see whether early intervention by OMT, together with other supportive treatment, would decrease the prevalence of sleep disorder breathing in children and in adults. So I think it's really a hot field waiting to be explored. And I think that the resources in Asia is far less than that in America. And we need some not too high-tech management. Okay? And of course, OMT would not be too high-tech to acquire. And we got a lot of good people, good practitioners that could really be trained quite rapidly. So looking forward to working with OMT and all my colleagues here to bring this field forward in Asia so that more children in this continent would benefit from it. Thank you very much.
Thank you, Daniel. I know I would kind of call you a serial founder of societies where you see a gap in medicine. One of the societies you founded was the Asian Pediatric Pulmonology Society, which is a dynamic collection of leaders from ministries of health, leading hospital groups, and universities from all across Asia. And in your second Congress, which was in Singapore, it was a wonderful surprise to see you bring together an editorial board representing the best people, most published people in sleep medicine in the world, with a proposed update for standards of care for pediatric sleep that included myofunctional therapy in the approach. And that was very exciting to see. But maybe you can talk a little bit about your journal that your society has been launching with a collection of other scientific societies based in Asia.
Yeah, thank you very much for reminding me that, Mark. Our journal is a young journal for a few years, and we're trying to provide a platform for researchers globally, especially in Asia, to share their results and to share their opinions. And in fact, in the coming year, we'd like to have a special editions dedicated to muscle training for the oral facial areas. I'm actually asked Mark to help coordinate, to collate some papers from our friends in this circle to set the scene, to let people, the doctors, nurses, allied health, to know about the recognition of who would benefit from oral facial myofunctional therapy and what exactly is OMT. I mean, OMT could mean different things from different people. So as I urged you previously, we need to define the management of OMT to sort of, I don't know how to label it, to sort of patent it as a sort of a well-defined area. So I really appeal to all my colleagues in this panel to help to promote this standard practice in Asia by submitting papers to this special edition devoted to OMT in management of sleep disorder breathing in children. Thank you, Mark.
What's the website for the journal and the name of the journal?
It's a PRCCM. You search www.prccm.org, you'll find that. Pediatric Respirology and Critical Care Method, PRCCM.
Pediatric Respirology and Critical Care Medicine. And I'm happy to announce here today, this will be one of a few select sites that will be able to publish the proceedings or findings of this Congress. And we're really excited about sharing this knowledge and some of the new data that's been presented. And we're really honored to have this invitation from you because we know it will find its way to some of the most influential medical leaders and researchers from across Asia and then the world. So We look forward to seeing you fast-tracked into PubMed, and we want to be a part of that. So thank you, Daniel, for your leadership.
Thank you.
Is Kevin Boyd here with us? I'm so excited to introduce Dr. Kevin Boyd. He's a pediatric dentist based in Chicago and has a master's degree in human nutrition and dietetics. He has taught and teaches at Lurie Children's Hospital, and he also has been doing some work at the University of Pennsylvania in the museum, studying evolution and the impact of our devolution on the airway, and really tracing it back to the human skulls themselves. So,
and he's a faculty member of our institute, the AOMT.
Indeed.
And he's on the board of the new society. He's actually co-president of the society you're on the board of. I'm on the board of.
The International Pediatric Orthodontic Society.
There we go.
Yeah.
Which will be launched in Geneva
Kevin,
next week.
I want to pass it over to you. Welcome.
So Kevin is not here yet.
Okay.
So let's move
We'll come
along.
back to Kevin.
To Katrina.
Katrina. All right. I see that you're here, Katrina. Katrina, whose work for the AAMS as secretary is just the tip of the iceberg. Her dedication and passion to finding clinical solutions for her patient population actually led her to us, to the Academy of Orofacial Myofunctional Therapy. She's a specialist in dysphagia and the infant population. And Katrina has done so much work looking at the impact in a public health setting, and her dedication to finding solutions inside public health paradigms has also been a huge challenge. And I would love her to talk about that specifically inside the NIH or the NHS in the UK. So Katrina, I would love to introduce you.
I just want to mention also, she's the recipient of a fellowship from the Winston Churchill Memorial Trust, which is a Queen's charity looking at funding and supporting and spotlighting key leaders on current issues of the day in the United Kingdom that will have an impact across the country in years to come. And her remit in winning this fellowship has been to explore how to put myofunctional therapy into the National Health Service in the UK. And so part of that journey, she spent about 6 months in residence with us here in Los Angeles, and she's joined us at several places around the world. So thank you for your passion and leadership, Katrina Rogers.
Thank you. Thank you, and thanks for inviting me to talk here. I am a practicing clinician, and so working in the national health system for a long time, I have developed expertise within speech and language therapy, working with children with dysphagia, eating, drinking, and swallow problems. And I think that I was very inspired by the work of the AMS, the AOMT, exploring myofunctional science as a treatment paradigm for a number of children who have difficulties. And so that led me to apply for a Winston Churchill Memorial grant to explore this in greater detail. And actually working within the NHS, and I think possibly for public health, and listening to Daniel Ng there, people don't understand tongue tie in my practice. And in the NHS, I'm brought in as a firefighter. So we're not always thinking about intervention. It's very admirable for, Brazil and the frenectomy policy that they have to screen newborns. But certainly in my experience, I'm often called in as the last person to look at a problem, and you kind of walk in and recognize real difficulties and how to treat that. now for this, I hope you don't mind, but I did prepare some slides which I wanted to share earlier. And so I think that I need to have access.
Go ahead.
Okay. So let's see. Sorry. Okay, share screen. Where are they? Here we go. I'm not the best
Just
on
press
technology, and
Press
here we go. So you know, thinking about public health and myofunctional therapy, part of the Winston Churchill is to write a report and to lobby for change in healthcare policy. I returned from my experience in the US and you know, brought back by COVID to the front line, and you know, working with children with issues with swallow associated with tongue tie. Some of the children I work with, they're not neurologically compromised, but they end up on tubes. And just to I'm just let's jump forward. Sorry. Just to share with you one of my little guys who came to me with feeding issues. He'd been seen by lactation, who didn't feel that he had issue with tongue tie, and he ended up on a tube. His mum was very distressed, parents very distressed, as Isabel, you know, shares. It's the psychological cost with all of that, parents fighting, anxiety, and this little guy was at the center of that. He ended up on a tube, losing weight, so I was brought in. I persuaded the providers to look at tongue tie. They kind of said, yeah, okay, we'll address it, but we're really not sure it's going to make any difference. I asked them to do it and share with them that I'll deal with the fallout in the therapeutic approach to deal with that. And this little boy came to so I saw him last week, and delightfully, and I'll play his screen, but delightfully, he started feeding orally. He's 5 months old now. We've done a lot of work looking at myofascial release exercises, working on targeting specific muscles to change the pattern for feeding. And at the end of this appointment, it was a big drum roll to remove the NG tube. So that was brilliant. But when you think about, okay, how to create change, it of course has to come from evidence and research, and actually, you know, thinking about changing practice in the NHS to stop that firefighting, prevention, absolutely. Again, I was working with the mum today, whose little girl again had a tongue tie, untreated tongue tie. This little girl was a mouth breather, and the mum was a nurse. But the mum actually was kind of, so what does that mean? You know, what does that mean for this child's health? So this little girl is 10 months. Her attention span was very poor. She was up and off. You know, I've been a speech and language therapist for a long time and looked at children with attention difficulties where they're struggling with their airway, that they need to move, they need to test themselves against gravity to support their airway, to establish, you know, diaphragmatic breathing. and looking at that aspect. So prevention is really important, having awareness, parental awareness, so that people know what to look out for. And I guess, you know, creating change, we need to think about an algorithm to measure the costs of not treating myofunctional difficulties across the lifespan. So in the National Health Service, we're always thinking about money, saving money, how can we refine things so that it costs less in time. I think that's probably across healthcare throughout, but it's almost thinking about you know the cost of treatments, the cost of healthcare appointments, the cost of children on tube. That's a lot of money, and if we can look at early prevention, let's move forward. You know, what are the test cases do we need to look at to bring this into public health? Who do we need to look at? Mark's mentioned, you know, people in older age with sleep issues. We've got, you know, people across the lifespan that you know, what's their background, how and why have they landed up with these issues. And I think that, you know, parents, our patients, they all have a story, and you know, working with younger people, you know, 20-year-olds who have always had TMJ issues, high levels of anxiety. What's that meant to their sense of well-being, their sense of self, all of that. It's relevant. So I'm going to take you back. Okay, so for you know, the little children, it's thinking about, and that little boy that I just showed you, parental anxiety and maternal depression and mental health, you know, really relevant to consider and to measure and to think about services. So the little boy, again, you know, the parents were at breaking point when I met them, and you know, that's not okay for supporting and protecting a little one. We've got failure to thrive, poor early growth, setting up patterns, very early patterns with the tongue tie of poor feeding, you know, relying on a tube, so not having the opportunity to develop themselves physically, but also if there's a history of failure to thrive, what's that doing to muscle growth, muscle function, ability to explore and engage with their environment. And then the child's poor health and developmental delay, you know, seeing children, we have an explosion in the UK of children getting diagnoses of ADHD, autistic spectrum disorder. Is that really the case? Is that really the case? People aren't looking at sleep. They're not looking at breathing patterns and open mouth breathing. And then the cost to healthcare system is acute need for ongoing health appointments and longer term costs to health requiring further treatment and management. And I think that we do have work to do in this area, and to look at bringing studies together to show evidence to create change, which is kind of really what set me off on the journey of myofunctional therapy and changing people's lives, changing people's health, which is what all of us are really interested in. So yeah,
Katrina, you know, you bring up so many points. There's so many, you know, this is kind of an onion peeling it back experience, because I'm just thinking about the maternal anxiety of not being able to feed your baby, plus any kind of postpartum experience, is such a physiologic, psychologic event. And I know that there's been so much public health initiatives to support postpartum and the experience of the mother. And it's just really interesting to see how we see the dovetailing effect between what's a physiologic phenomenon, which could be a poor latch, and how initiatives to support mothers with lactation and IBCLCs who are trained to identify and to understand positioning, et cetera, to support breastfeeding. I mean, these are measures that are public health events. And so if we can extend this into the knowledge base of our physicians and the community at large, so that they don't necessarily mean, you know, the risk of weight gain and losing weight is going to bring on kind of compound the cycle of that child's development with bottle feeding, et cetera. So I just want to say thank you for what you're doing. And it's such a rich environment to explore. Again, I go back to Isabel and your call to action to get psychologists trained to understand what these profiles and patient profiles look like, and the physiology that's really at the foundation of what might be driving that behavior.
Just to share, I think working in a kind of firefighting situation, and we for breastfeeding where the support just isn't there, and so parents, because of the will to feed their child, end up bottle feeding, and that's setting up, you know, difficulties for life. And you think about children coming out of special care baby unit who've been intubated, high arch palates, you know, it's always a wait and see, and there's a real call for prevention, intervention, early intervention, and you know, that's where my passion comes from. But just to yeah, just to share that.
Great, thank you.
You know, this discussion leads me to mention the artwork. Each of our 9 fora has its own kind of artwork, which is a little bit telling a story. And I'll just hold this up. We'll edit this in so it'll be clean. But if you've seen the artwork here, we've got an image of death at a water pump. It's called Death's Dispensary. And people are drinking from it, and death's there pumping away, pumping away. You know, when Daniel was talking about, you know, air being compromised with pollution, you know, one of the themes for our Congress is when air is not air, food is not food, sleep is not sleep, there's aamsinfo.org. And we're exploring all of these tremendous changes, but we'll have at aamsinfo.org this series of artwork in our eventual final, still being assembled Congress program. You know, this helps tell the story, and these panelists help tell the story. This person here, this image of this person here is John Snow, and he's credited with being sort of like the founder of the field of public health or the discipline. What he did in London, you see there's a map, he started tracking cases of cholera and popping up on the map here, there. You know, there's got to be a connection. And it led him to zeroing in on the water supply and cholera getting into the water supply. And this had a profound impact. It's so crazy that, you know, this wasn't discovered or we weren't thinking about this. I feel like we're really onto something here in myofunctional therapy of a similar level of importance. And we really, when we're able to look at the, you know, public health implications, when we get, like Shannon Sullivan was talking about, or Daniel Ng, clearer definitions, We do this validation study that our international research consortium on orofacial myofunctional therapy is in the process of developing and planning. We really, I think, have an opportunity to have a huge impact on public health, and this really excites me. So I just wanted to point out that artwork and tie it in, because what you're doing, Katrina, has a profound opportunity. I don't know if one of perhaps your future colleagues has joined us, Aditi Desai. I know she was delayed with a patient. Aditi, are you on yet? Or maybe she's going to be joining a little bit later.
Later.
Okay. So do you want to introduce the next panelist?
Yes. Denise DeWall. Yay, Denise. It's so good to see you. Denise, for those of you who don't know, was introduced to myofunctional therapy in a way because she had her own personal story with her daughter who had obstructive sleep apnea, and she was looking for solutions. And with that kind of curious mind and investigative nature, she, as a physician, went further into sleep medicine and is at Case Western under Kingman Stroll doing a 2-year residency, I believe.
A 2-year NIH fellowship.
NIH fellowship.
Yes,
So
research fellowship.
Anyway, research fellowship. We need you, Denise. So yes, please join us and let us know.
Denise also is recipient of a new award we gave at our Hippocrates Gala, the Chrysalis Award for transformation and positive potential impact on medicine. So we're really excited about your work and your future work, and you've got such a tremendous story, and we're so happy to have you engaged. Thank you for being here today, Denise.
Thank you for having me. And I'm calling in, so I'm actually on video separately just because I have bad internet here. So one of the things that I want to really bring to the table is that we're in an echo chamber in the myofunctional community. It's kind of like we see that the world is round, and a lot of people think it's flat. So there are thought leaders in sleep medicine, like at Harvard Medical School, who don't think that nasal breathing is important. And like at the last sleep meeting, I remember getting into an argument with a vendor in the vendors. They got this oral appliance which forced oral breathing, and they're like, the mouth, it's less resistance when you breathe through your mouth. And I'm like, no, it's not. And so we understand things that most people don't. And so we need to build awareness in the medical community so that people get this, because we're not going to make any progress with people not knowing it. And, I am board certified in internal medicine. I am board certified in pediatrics and sleep medicine. And I can tell you in internal medicine, pediatrics, there was not a single question on breathing, about nasal breathing or oral breathing on those board exams. The pediatric sleep medicine community, they get it. They understand that mouth breathing is bad. But the adult sleep medicine community, not so much. Some do, some don't. So I'm thinking, like, one thing that may be able to get through to people is providing like free continuing professional education credits by doing just like, the 2 days, just like the myofunctional training course. That may be one way that we can like bring people, like give them a little carrot. You get free CME credits to bring some education in. So that would be one of the first steps. And then the other thing now, as someone who is a primary care physician in the south side of Chicago, and there was just tons of mouth breathing going on in there. I'd say like 80% of my pediatric patients were mouth breathers when they walked in the office, and very high rates of chronic diseases. But we really need longitudinal studies to show that mouth breathing is bad, because there just is not awareness in the medical community. So we need basically a Framingham heart study type study, longitudinal study, going 50 years. It's going to be expensive, but it's a public health imperative to show that this is important, just like cholesterol is important. Breathing through your nose is important. And unless we can show that there's going to be cost savings with healthcare, there'll be improvements in educational outcomes, and there'll be improvements in productivity, like decreased rates of disability. Like, we are not going to get buy-in from the payers in healthcare unless we have this. And this has to go through a public health system, and it's going to have to be in a country that's not the United States, because funding public health is not, you guys can see, public health is not a priority in the United States. Like, I don't know how better to like show it as like the COVID outbreak. But a country like Sweden or France that has a national healthcare system that you could do longitudinal outcome data research, and there may be even data that can be mined, like dental studies in Sweden. If there's longitudinal studies, we could see, are there mouth breathers who are like kids who are 5 years old, mouth breathers, what's their health when they're 55 years old? And we need that data to really convince people that this is important. And unless we do that, we're not going to get anywhere. We need this really hard data. And then the last thing, and I love the Brazilian tongue tie law. I want to throw out here that baby bottle nipples, there's no regulation whatsoever on what do baby bottle nipples do to children's oromotor patterns. And, you know, I gave my lecture on the soft palate, and like, there's a very specific interaction between these muscles of the soft palate that's required for normal suckling. And we need to really have laws that infant nipples have to replicate that movement. Because if we don't have that, we're getting kids off to the wrong start from the get-go. And so that to me is like one of the holy grails for public health, is like, make sure our infants are fed properly, so that we're not like trying to fix mouth breathing in a 9-month-old who can't follow any sort of myofunctional therapy because they're too little, they don't get it. But so those are my 3 cents.
You bring up so many pertinent, relevant, the zeitgeist of our nation focused on science and how we can actually impart. I did read an article that showed that mouth breathing has a higher susceptibility for COVID-19 response. So it does feel like we are in this very unique, special time where we can, because of COVID, look at breathing and mouth breathing and what that does to the system. So I hear your pain, and I also understand that we might have an opportunity here, which is part of what we're doing, is collecting people and the public to put the spotlight on breathing, because we're all impacted. Absolutely. One more thing I wanted to ask you, Denise, is the education is one piece of it, and then the treatment. I love what you said about giving continuing education credits for free so that we can get this information to more clinicians, more physicians that may not have had it in their curriculum. That's a really novel and excellent idea. I think it's powerful.
I second that notion. There's a center for research in interdisciplinarity in Paris, in the Marais. And they give out degrees from University of Paris, René Descartes, University of Paris, Diderot. And they also have tremendous public-facing programs. And they have a MOOC studio, a massively open online course studio. And they've invited us, our institute, to come in there at some point and maybe do a program, or we've had some discussions where we can push out this information. I think once we get more data sets, you know, Denise, this is such a brilliant idea, and we can push out trainings, you know, for clinicians, because, you know, this is on some level, we had a technology forum on Monday, the amount of demand that's going to come when, you know, kind of this genie's out of the bottle in terms of knowledge about what impact myofunctional principles and therapy can apply across the lifespan. will create so much demand that there'll be, you know, a lack of clinicians, a lack of training, and the technology solutions that we can apply for gamification or delivery of training become issues that we have to think about strategically. So Denise, did you have a final comment?
No, we're good. Thank you.
Okay, great. Thank you.
Who is next? Nicole. Nicole Archambault. It's so great to have you here as a speech pathologist who has dedicated her life to understanding how to support children and parents in the journey, and through function and development and interaction. Your presentations have always brought so much information, not just to the speech pathology community, but to the wider scientific community. And it's really wonderful to have you here. It's an honor. And you are truly just a clinician who's dedicated her life to helping kids and parents. Also, the parent element of this is so important as a therapist, how to support parents be better with their children and in their own development. So it's really great to have you here. Thank you so much.
Thank you, Samantha. Thank you, Mark, and all of you. I feel truly honored to be amongst this panel. Can you all hear me okay? Are we okay?
Yeah, we can hear you. We just want to make sure your
We'll pull you up.
is
Yeah.
pinned. Yeah, pin
1
the
second.
video.
And also to our panelists, if anybody shares their slides, make sure you unshare your screen or stop sharing your screen.
No, yeah. So just pin video. Okay. All right.
Should I share my screen?
There you go.
Yeah.
Yeah, sure. Okay.
Welcome, Nicole.
Thank you. Thank you, Mark.
Nicole Archambault, one of our fellow Angelinos. Woo-hoo! Go Los Angeles.
All right. Well, you'll only say that if I can successfully share my screen. So, oh boy.
Well, in the interim, I have a little symbol we can put on camera. I don't know if we can cut in, you know.
She can share her
You
screen.
switch, you push the button.
No.
Okay, you don't push the button.
I don't.
Okay, don't worry about it. Go. You ready, Nicole?
Well,
Are you able to share?
do you, okay. It doesn't.
Well,
Yeah, it's fine. Here. Make Coco. Okay, there.
I mean, I can
now you
start-
can share your screen.
Yeah, go.
Go ahead and share your screen, Nicole. If you go to,
Okay.
there we go.
Are we good? Can you all
Yeah,
see
just
this?
press play. Press play.
Thank you for talking me through this. Oh,
Yep.
hold on. I'm coming. I will get this. Maybe. Okay. Hold on.
This is such an exciting project, and it's been a real pleasure working with Nicole over the last decade or so and seeing all of us work on developing these programs. So you just go to play, all you do is play your slides, just like you were going to give a
Slideshow,
presentation.
Slideshow, then play.
So this is how COVID is helping me. I'm learning all kinds of new technology. I think we're on there, right? Are we good?
Just slideshow and play.
At the bottom of the screen on the right, there's an icon of like a little, you know, TV screen or something like that. You push that one. It's on a little podium, a little stand.
Well,
That
it
is,
says share. I've got more. Pause recording. It acts like it's recording here or doing something. Is it?
you know, don't worry about the
worry.
recording button.
Don't worry.
All you do is go through your slides. Just go through. Go ahead. Go ahead.
Okay, so I think you guys, thank you for having me. Thanks to all of you. I think we couldn't be talking about a more important public health topic right now, and it's one that certainly we do have to get out to parents. And one of my passions has been when we look at the ramifications of airway function disorders and what happens when an airway is compromised, be it in the daytime or through sleep-related breathing disorders at night. there is a profound impact on the whole being of a child. And it's not just children we're looking at. As Samantha said, we do look at the consequences to families. And so my passion has been, as a speech and language pathologist, seeing all of the areas that really get impacted when our airways are not optimal for children. And so, you know, that can look like in a school environment, like executive function skill issues, which is all that frontal lobe stuff when we get into attention and problem solving and creating novel ideas and just being able to self-regulate, right? And getting kids out of that limbic system and into more of a parasympathetic state so that they can function and access their prefrontal lobes for academics and socialization and good speech and language that's really functional for them. So I did a year-long graduate certificate program at Johns Hopkins, and my capstone is kind of what you see here, which I'm just going to touch on a little bit as we talk here. But my big passion is if we're looking at the whole impact to a child, and we can see we've got great panelists here in the medical community, but we've also got this impact to children in education. And somehow in recognizing all of the silos, we've got to, again, kind of tear those down and build the bridges. And I think there needs to be a bridge between medicine and education. And we can't continually say, well, this is a medical issue, we're not going to deal with it, or this is impacting a child at school, it's not relevant outside. It most certainly is. And so we know the impacts of sleep disordered breathing. We see it in clinical practice. There's more and more research all the time. And again, mouth breathing. I think Dr. Sullivan brought up earlier the Avon study. There was also a study done in Brazil in 2008 by Abreu and colleagues looking at 3 to 9-year-olds, and they found that 55% of those children were mouth breathing. And so I think bringing educators into this screening process, right? Because we're all looking at prevention, and I think prevention has got to start with screening and awareness. In the Los Angeles Unified School District, which is the second largest school district in the US, children, when we're not in COVID, are physically in school 180 days a year. And teachers or educators have about 32 hours a week where they have access to these kids. And they get to see what their behaviors look like, what they're learning and their executive function skills are, so they can bring robust information to start coming is part of our team, like just in bringing them to the table in the screening process. In the US, we have 3.2 million full-time teachers in primary and secondary schools, and they're serving 35 million children between pre-K and 8. So when I was looking at this capstone, and this does not, if you're an OT on this listening in today, or a physical therapist or a nurse, or a dental hygienist with a myofunctional background, there can be other people that go into schools, other disciplines, who, if they are aware of myofunctional disorders and how to start picking these things up, can be collaborating with teachers in the screening process. So,
Cole, do you want to go through your slides really quickly?
Yep. So can you guys see the next one?
Well, it's easier if you press play, and you know, there are icons on your PowerPoint.
Just go
down to
slideshow, play.
You drop down the drop down of slideshow. You drop it down. You hover the cursor over slideshow. You drop it down, and then you can press play.
Sorry, I've been moving them. I thought you guys were seeing them. Are they
No,
not?
you have it. You need to press play. Or
icons are at the top. I have stop video, participants, new share, resume share.
Okay.
Sorry, guys.
Why don't we go back to,
You know,
well, what we'll do, Nicole, we'll get the slides in later.
yeah, we'll edit the slides in later. Just go ahead and talk through them. Say slide number 2, number 3. Let's carry on.
Okay.
So have you gone through all the slides already?
No, I've gone through the first 2, so now I'm on slide 3.
Okay.
Okay.
So click on 3. Click on 3.
So
I'm
just
sorry.
talk through them quickly. We'll edit them
I
in.
think we have to take you out of slideshow and you can just talk about
Yeah,
it, okay?
Okay.
just stop sharing your screen.
Okay. Sorry, guys.
There we go.
Clearly technology.
That's okay. Just
Okay. So really quickly, this whole capstone was, to increase educators' knowledge of the airway and the impact of optimizing the airway for sleep and functions. And then what is the widespread impact when we don't have healthy airways? And how can we facilitate our collaboration with them? And how do we manage the recommendations and next steps? Because screening without next steps doesn't mean anything, right? And it would be a public health disservice not to give people the information of where you go from here. So in this 4-step model, really, I was looking at educating educators on classroom behaviors that they can be looking at in children. Okay, some of those things might be, are they seeing more aggression? Are they seeing more bullying? We know that children with sleep disordered breathing are 50% more likely to exhibit bullying behaviors. They struggle to self-regulate. So those are kids who will have more emotional outbursts in a classroom or be easily distractible. And they kind of have that constant battery, like adults, we think, oh, they didn't get a good night's rest, they're tired, but children will be peeling them off the ceilings when they haven't had proper sleep. So their systems just kind of amp up so they can try to stay focused and stay awake in a day. And that's all information. When we look, one of my slides, I'm going to pull it up here for myself. But when we look at some of the data, we know that sleep disordered breathing and ADHD share many common neurobehavioral symptoms. That was from Halboer and colleagues. And the ADHD rose by 43% across the US between 2003 and 2011. And the reason this is important is because teachers all the time bring children to IEP teams. That's the individualized education plan when there's red flags for problems in class. But they do not get any training in what would it look like if a child was mouth breathing or had sleep disordered breathing. So when we talk about the costs, we're spending a lot of money as a society when we're maybe medicating for children for something else when the underlying issue is sleep disordered breathing, and maybe they need orthopedic remodeling and myofunctional therapy and dietary changes and some other things that the interdisciplinary team can bring to that child and to the table there.
well,
So in this 4-part model, we would train teachers in the physical observations that they can look for. We would also classroom behaviors, physical observations, and then do parent sleep screenings. This could be the PSQ. It could be the childhood sleep habits questionnaire, the BEARS, and then SLPs. We know from looking at orofacial myofunctional disorders, we can use these as clinical markers to pick these kids up. So I think that the cost to children and to society is really more than we can even imagine. If any of you are parents, you think, what would be the cost of your child's life? And the foundation for health across the lifespan begins right now in childhood. And we get one shot with these kids to do it right. And we do it right in a preventative sense too, when we screen and we can start getting a good differential diagnosis and knowing what we're treating, but using all the team players and having medicine and education kind of just come together and view this for what it is. You're dealing with a whole person, you're dealing with a whole family. Sarah Johnson at Johns Hopkins says we must protect people's potential. And I think that's one of the best quotes when we really look at children and individuals that are going to grow up into adults. So I don't know, I echo the same sentiments as all of you that prevention is key. I'm a strong advocate for screening. I don't think we can underestimate the issues that we see in society when we do not have optimal airways. So I'm all for whatever we can do in different countries and across our teams to moving this agenda forward. Thank you.
Well, you really highlight the resources we already have, which are the teachers. And I think that's something that has been discussed very much, and how we can get that community more on board. I know we're living in crazy times right now, and teachers are overwhelmed more than they ever have been. So when we talk about the infrastructure of how to build back to protect the potential of the child, that's a great quote. I do feel with you that teachers and educators are really on the front lines. So wonderful. Thank you.
You know, Nicole, it's such a beautiful project. And I think there's so much tremendous potential for screening in schools. The opportunity is profound. And there are something like 80,000 school-based speech language pathologists in the US. We have a colleague, Liliana Zamijak, who couldn't be here today. She's a tremendous caseload. She was a professor at Florida, University of Florida, and she relocated to Southern California to help support her mother. And so she has a PhD, her thesis was on dysphagia. And so the school district in Redlands wound up having a great resource in a local hire. And there she is screening kids in school district. And, you know, the kind of standard approach in these school-based speech pathologists is to focus on performance and language in education. But if you have a sleepy kid who's falling asleep in the class or rocking in his chair and acting up, it's going to have an impact on, you know, their school-based performance. If they have sleep disordered breathing, if they're bedwetting, if they're not getting stage 3, stage 4 REM sleep. So she decided, with her training as a faculty member of our institute, the AOMT, that she was going to work within her scope of practice as a speech language pathologist and identify a potential referral for sleep apnea or sleep disordered breathing as a school-based performance issue. School districts are very hesitant to do something because, like, if you touch it, you know, you bought it in a sense from a financial perspective. She has had actually 11 cases now where she's suggested to the students that they need to go in for a sleep study as a performance issue in the school district. Every one of these wound up in court in a lawsuit, and everyone has been victorious in favor of this child getting treatment as a performance issue. So Nicole has, I think, been featured 3 times on the ASHA Leader. It's a peer-reviewed clinical journal from the American Speech Language Hearing Association. And she's done such tremendous work and leadership. I suggest that you look up her articles. She posits questions like this: how can we not look at school-based performance as it relates to sleep disorders as speech language pathologists? So if it's in a speech language pathologist scope of practice to screen for orofacial myofunctional disorders, which we've established it clearly is, and these sleep disorders are comorbid to these myofunctional disorders, which I can say after this Congress, we have established that. We have several, you know, not just case study papers at the bottom of the research pyramid, but we have, you know, cohort studies. We have meta-analyses, one of which is just coming in on pediatric sleep disorders and myofunctional therapy from Anusha Bandarpay and Macario Camacho. It just got published in the Journal of Sleep Medicine, and we're really looking forward to that contribution. And Riley Children's Hospital, University of Indiana, becoming a part of our International Research Consortium. So thank you, Nicole, for your passion and leadership. And I think there's so much tremendous opportunity for us to be able to come to that. So we're going to move along and shift gears.
Wait.
Yeah, go ahead, Nicole.
Just touching on what you mentioned about Ileana and her work, because we all come up against this, I think, in the schools, because schools are under an educational mandate, and that's how they decide what they do and what they cover. But if you think of schools, they screen children's vision and they screen their hearing because there's no question how important those are for learning. But again, it's educating people on the value of the airway. And it always amazes me that we all have to show all this research on how important breathing is, because if we didn't have a pulse, nobody would be here having any of these conversations. Our straight teeth, our crooked teeth, our speech sound errors, our perfect speech really wouldn't matter. So I think it's going back and just putting breathing and sleeping up at the top of what we do and carrying that message out. So hats off to Ileana.
Yeah, Liliana Zmijak, we love you. And, you know, there's tremendous opportunity here in exploring the nature and relationship of screening within the schools, not just in the United States, but worldwide. Maria Pia Vila, as a result of a symposium that Liliana participated in that we organized with Stanford Sleep Epidemiology Research Center, our institute, the AOMT, 4 years ago, you know, she created a screening which just got published last year also in the journal Sleep Medicine, which we love, on screening 716 grammar school kids in Rome for tongue tie, and then studying them having you know, such a tremendous correlation to sleep apnea. And so it opens up this whole can of worms. We can help these kids perform better and, you know, help them throughout their lifespan with easy diagnostic tools and criteria. So anyway, I'm excited about the public health opportunities and prospects that can come out of this, which leads me to, I'm going to introduce them as a pair. So Dr. Silky Weber is a friend. We've gotten to know each other at congresses around the world for the last 8 or 10 years. She is a pediatric otolaryngologist and sleep specialist, and she also works in myofunctional therapy. She's at University of Sao Paulo, UNESCO campus in Sao Paulo State, and she's author and co-author of such great work, and more in the pipeline. She's on the board of the AAMS, and she's also on the founding board of a society starting up next week, the International Pediatric Orthodontic Society, and which I'll introduce Daniel Brunetto, who's an orthodontist from Brazil in a moment. He's also founding, but we're talking about a public health project in Rio de Janeiro that we want to be a model for sites around the world. Thank you for joining us, Silky. Go ahead. Silky, are you there?
Hello. Yes. Hello. Good afternoon, good morning, good evening for everybody. Thank you for inviting me. Thank you for this presentation. Wonderful to take part of you. And as we had been seeing during all the AAMS Congress, it is so important that we have this multi-professional interaction and discussion, because we are working isolated, so many different aspects, but in fact it is absolutely necessary that we work and that we plan together our future actions. So certainly looking at the International Pediatric Orthodontic Society, having multi-professional members is fantastic, is tremendous. And bringing the problem of mouth breathing, of sleep disorders to the strain of public health, and to make people more aware that it is important not only to look at hearing and vision, but you have to look at breathing and you have to look at sleep quality. These things are, these items are really, really important and have to be established in public health. So we have to work, yes, work and work and work and work to make people aware. And Daniel in Rio de Janeiro, he has a very, very nice project. So I got it to him so he can present the project. Thank you.
Thank you, Silky. Just to introduce Daniel Brunetto. Daniel, I think at a very young age, has taken on quite an ambitious program in his learning. I know he did graduate work in the orthodontic department at UCLA, where we met, where our institute has offered training in myofunctional therapy. And Daniel has gone back and he's doing a PhD in Rio de Janeiro at Federal University of Brazil in Rio de Janeiro. Daniel, I think you have to pin his video. Daniel is joining the board as a founding member of the International Pediatric Orthodontic Society. And our Congress, our society is going to be a partner in the World Sleep Congress in Rio de Janeiro, Brazil. This is press release is coming out, but it'll be in November of 2023. And in anticipation with that, the orthodontic department chair, Lincoln Najima, at Daniel's school there, and with Daniel and with Silky, and we'll work to build a consortium of universities, not just within Brazil across disciplines, but also with different sites around the world. But our idea and our dream was to kind of use the joint congress of the AMS and the World Sleep Congress as a focal point to ramp up and get this pilot project together to screen in schools and to screen in the clinical population of orthodontics for orofacial myofunctional disorders that may be related to sleep disorders. And I think we have a tremendous opportunity to create a bridge between orthodontics, sleep, and myofunctional therapy, which will be profound. And I know they get a lot of data potential points at this university and some others. So welcome, Dr. Brunetto, and thank you for your vision and leadership.
Yeah, hello. Thanks, Mark. Can you hear me?
Yeah.
Yeah, so thank you. I know Mark about 5 or 6 years from now. And we know as orthodontists, I really believe that it's much more than a straight teeth or a beautiful smile. We know the medicine behind it, so that's what we're trying to prove. But, to do that alone, it's a really long shot, because it's not really easy to change people's mind about this. So that's when I met Mark, I was really happy that he's struggling on that. And now he has all this support from you all over the world. And, what we can do to make this happen here in Rio or Curitiba, where I am, we have to show data, we can't just talk about it. We have to show data, science, and that's what we're trying to do. And we're gonna put this project forward with Silky help, and any other that want to collaborate, we're open to that and build some nice evidence-based projects.
Thank you very much, Daniel. And I'm so excited about this project. I just want to give a shout out to Fabio Babancos, a friend and a colleague and the board of Turma do Bem, doing a good term. It's the largest professional volunteer force in the world. I think they're in 23 countries. It started in Brazil with 50 dentists in 2005, adopting the dental care of an underserved child until they became 18. And it grew into this profound organization, multinational NGO that's won the Ashoka Prize, been featured in the World Economic Forum a number of times. And I really think that there's some tremendous potential here of looking at the model of what they've done in terms of intervention in a public health manner that could very quickly ramp up. Like we've had many conversations with Fabio Babancos and his team about the prospect of dreaming someday of training all 20,000 plus of these dentists to screen for myofunctional disorders, and the kind of results that would come beyond that, just beyond the traditional dental interventions. They do such profound work there. And I think by gathering this data with this project in Rio de Janeiro, and hopefully some other sites that we'll be able to announce soon, we can really tell a great story and have a protocol for this kind of team approach and interaction, which is very exciting. Thank you, Daniel.
Thanks, Mark.
Okay, I know you're running between patients, and I appreciate you slipping in some time here today.
Okay. Busy day here.
Okay.
Thank
Okay,
you.
muito obrigado, Silky and Daniel.
Thanks, guys.
Okay, I think our last panelist today is Dr. Karen Sproit. Karen is not only on the board of the AAMS, our third board, she is also a founding board member of the International Pediatric Orthodontic Society. And it's been such a wonderful privilege to get to know her over the last 8 years or so. I think we first met when my mother, Joy Moeller, Licha Kochiani-Pasquet, and myself were invited to speak in Grand Rounds by Leila and David Ghazal, University of Chicago. And, you know, being passionate about pediatric sleep, we would spend time together at congresses around the world. And, you know, we had 3 symposia at the International Pediatric Sleep Congress in Porto Alegre, Brazil. And I think she was kind of like, wow, these guys, you know, maybe we just got to start watching them. And she was stolen away from University of Chicago to the French NIH, INSERM, the French National Institute of Health. And it's a real honor and privilege to be able to introduce her as a colleague. Our institute, the AOMT, has formed a consortium of sorts with INSERM. And we're going to be doing several research projects, including PhDs for some team members in neuroscience, and publishing, you know, at least, you know, 20 or so high impact factor papers, and helping support research projects. And you know, if you ever have the privilege of working with this person who's a recipient of our AAMS Rising Star Investigator Award for great promise in the advancement of medicine involving myofunctional therapy, you'll be very lucky, because she's a great advisor and passionate for helping children and helping their development. And thank you for your contribution here at this Congress and in this work, Karen.
Hi, Mark and Samantha. Once again, you're doing a great job. It's tremendous how you are doing this for a full month. And so thank you for having me here.
2 months. 2 months.
2 months. You see, I lose already track of time. So even you go fast speed. So anyhow, so thank you. And so to today's talk and for I've caught some words and some concepts and some summaries. So when we talk of public health, really, if we talk of public health, that really means promoting health. And if we mean promoting health, it means really putting the focus on a quality of life. So now let's think about quality of life, irrespective of our professions, because all of us are impacted by it. So quality of life means, you know, and focus on the orofacial area. It means smiling. Your first smile as a baby, very important, because it interacts. It gives a first step in your communication. It is also your facial expressions, orofacial area. Next to that, it is a speech. So social communication, and I can put the development of a child next to it. Next to that comes the social communication. You also have the track of feeding, alimentation. So what Katrina also said, the swallowing. So swallowing, food intake. And then the other one is the breathing aspect, where you then have the sleep issue. So you really come to these, you know, core elements of the very beginning of your life that will impact already very early in life and to the rest of your life, your quality of life. So all these aspects of breathing communication. Communication, as we heard about, it's not only, you know, how the child smiles and uses this orofacial area, but also how the parent will respond. And especially when the child is not capable of smiling or is not smiling the way that the parent is expecting it, or the feeding is not going. So that interaction, that reciprocal aspect of the communicating, social communicating, the feeding, the breathing, swallowing, drinking, all these components in the orofacial area are linked to functioning. And so functioning, you know, needs to be screened at the first spot if you want to do a public health intervention or public health awareness or public health promotion. So screening is a word that I've heard so many times. So screening is part of this endeavor of public health initiatives. And I think I can summarize, and I've written it down because Katrina said it so beautifully. So it is the ability for a child, a young child, the ability to explore and to engage through that breathing, through that communicating, through being able to swallow, drink, eat, and as a consequence have proper sleep, and as a consequence have a good development, have a good interaction. So I do believe that if I put it like this, that this is a societal responsibility. This is not only a medical or one profession responsibility, it is the teachers, it's everybody, even the parents, everybody included. So societal responsibility to screen for something that will improve the quality of your life. And that would be focus on that orofacial area and see how that functions, and then train it properly. And so thank you very much for bringing me back into this public health and the forum of today. Thank you.
So wonderful. Thank you so much. You know, putting these ideas together is really the point of us coming to the table. So for you to succinctly do that for all of our benefit and for society's benefit is really, again, that role of public health. And I'm sure everyone feels the same, that we are at this table and we're bringing in unique insights, and with that come questions and obstacles and challenges. So what I would like to ask now is if any of our panelists or anyone has any questions around these areas or issues that are seemingly something that to take into consideration, having listened to each other today.
Any final comments or questions or statements from our panel?
Well, I do feel that, you know, there are gaps in education, and part of what we're trying to do with these live videos and putting them on YouTube is to actually open up and crack open the dialogue with the public. And the public is getting more information just by virtue of the time we're living in, especially about breathing.
Our fora, this is the seventh one, the 6 that have come out so far have been viewed hundreds of thousands of times as a feature of this Congress that is public facing. And we've had well over 1 million page views, different aspects, things like that. I don't even know how to wrap my head around the analytics, but we really are just, people are like, oh yeah, this is great, this is exciting, we're all touching these things. We're only just over 1,000 people in this Congress and a planet approaching 8 billion souls. And we know that if there are 1 billion people suffering from sleep apnea, which is a very advanced state of disease, we maybe have another 1 billion that suffer from, you know, the higher category of sleep disordered breathing, including snoring, upper airway resistance syndrome. That is a profound segment of the entire population of planet Earth. And even if there's just a small subset of these, like Denise DeWald has talked about in some of our other discussions and presentations, we need to zero in on the phenotyping to get more specific. But I think we're talking about, you know, hundreds of millions of people here who can benefit from this knowledge. And if we intervene early enough, the profound cost savings. Jim Beddoes went through an exercise. He is part of a think tank at Stanford that looks at big data. And he went through an exercise, and this is actually going back to 2018 in advance of our third Congress in Rome, and put in some of the analytics for our work and scientific literature into a giant big data engine they have. And he said the kind of result in the kind of cost savings is in the trillions of dollars just in the United States. So I think we have a profound opportunity. I thank everyone for their time here today. You viewers, join us, aamsinfo.org. Please come on board, become a member, get engaged with us. We have so many more exciting announcements to come. We hope everyone will join us for our next public forum, which will be on baby and infant myofunctional therapy. It'll be a nutritional component, which I think is so huge, from Robert Lustig. But this kind of therapeutic intervention is way overdue. It'll be 9 a.m. Pacific, 1800 hours Paris on Tuesday, the 22nd of September. And then on Thursday, the 24th of September, we will have another forum on research priorities. Same time, 9 a.m. Pacific, 1800 hours Paris. And then we will have open to the public our closing panel discussion, the same time, 9 a.m. Pacific, 1800 hours Paris on Saturday, the 26th of September, followed by a closing ceremony, which will be so remarkable, some exciting surprises, people being honored for lifetime achievement, who you will not want to miss. This will be open to the public. That will be at 10 a.m. Pacific time. Get ready for your cocktails. It'll be a cocktail reception as well. Somewhere in the world it's nighttime, including Paris, which it will be 7 p.m. or 1900 hours, 2200 hours Tokyo and Seoul. And so the following day, which will be the 27th. So join us. We'll be announcing our next 4 AMS Congresses, including the International Pediatric Orthodontic Society, which the AMS is helping incubate, partnerships with World Sleep Society, and some great surprises around World Sleep Day next year in March 13th of 2021, and really mind-blowing stuff. So stay tuned and join us.
And thank you again for tuning in, and wherever you are, we really want to hear from you. So
gallery,
ta-ta for now. We'll see you at the next event, and thank you all of our panelists from around the world.
Oh wait, we had a late breaking edition. Dr. Kevin Boyd, do you want to say something?
You want
to say hello?
No, my partner and I had some untoward circumstances in the office today that could not be avoided.
Oh, that's okay. We love you, Cabo, and a lot of great news shared here. Do you have any simple statement about public health?
Well, I think we are dealing with the biggest public health dilemma in the world right now, and it's an oral health problem that is not tooth decay or gum disease. And the American Dental Association, Endeavor, and thanks to you, Mark, with the organizing, connecting all the organizations, sleep and airway hygiene is going to be on the list of the 3 main problems in oral public health oral disease. So, and please look at the World Health Organization's initiative on ending tooth decay in children. I had no idea it existed, but there's a plan to end tooth decay so we can focus on other things like airway and myofunctional disorders. So World Health Organization just hit ending tooth decay, WHO, January 2020. It's a big deal. So thank you. Sorry again.
Okay, well, thank you. Our last statement from one of our founding co-presidents of the International Pediatric Orthodontic Society. We'll have some statements about that, our closing ceremony. on the 26th of September. I hope everyone has a wonderful evening, afternoon, and morning, wherever you are.
And if you're seeing patients, keep going. The world is watching and everybody is saying thank you.
Giddy up, tongue wranglers. Yeah!